All right. Hello, everyone. Welcome to High Rounds today. We are very pleased to have Dr. Ron Ellis, who is our favorite neurologist, and whenever we have an issue, we usually call on him regarding anything neurologic. He's a professor of neurosciences at UC San Diego and a physician scientist whose laboratory and clinical work seeks to delineate how pathological interactions between HIV and its human host result in nervous system diseases such as dementia and peripheral neuropathy. At UC San Diego, he has built a program in HIV neurology that encompasses clinical service, clinical trials research, and laboratory investigations of HIV neuropathogenesis. The research component addresses topics such as HIV neurocognitive disorders, CNS effects of antiretroviral therapy, viral compartmentalization in plasma and CSF, and antiretroviral pharmacology in the CNS. He contributes both nationally and internationally to neuro-HIV research, and we are certainly glad to have him here at UCSD. So Ron, go ahead and take it away.
Thanks, Dan. I am going to talk today about two different studies, both based on the CHARTER cohort. So let me start with just an overview. So I'm going to be talking a lot about the impact of persistent neurobehavioral difficulties, and by that I'm referring to both cognition and depressed mood, even in virally suppressed people with HIV. And there is a positive message coming here that I'll go over in a few minutes. A lot of the work the first study used these multidimensional biopsychosocial phenotypes that try to better reflect the complexities of clinical presentations. And then I'm going to talk about the second part of the talk is about biomarker compartmentalization. Okay, so study one. Here, this is looking at these longitudinal multi-component biopsychosocial phenotypes in relation to baseline medical predictors. And the background, as many of you are familiar, is that even with viral suppression, a lot of people still experience neurocognitive problems and depressed mood, and they have very substantial impact on quality of life and even antiretroviral and other medication adherence, but they also have been shown to influence survival. The mechanisms are probably multifactorial, but given the excellent virologic suppression we get nowadays, I think we have to think about things that are beyond just viral control and how they might contribute to our patients' overall well-being. So the background here is that in the past, people have tended to be kind of siloed. They historically focused on isolated dimensions like cognitive impairment alone or mood disorders. But in reality, these things frequently co-occur and they interact with one another. So an example is that people, as we'll see in a minute, people who are depressed experience magnified cognitive and daily functional difficulties. Now, wouldn't it be nice if we could sort of leverage these multidimensional approaches to try and address individual differences in a precision health framework? We're not trying to treat everybody who's cognitively impaired exactly the same. We're trying to get a more complex clinical picture. And these approaches have been used in other fields, but the field or the use of these approaches is relatively less in HIV. So this is just a schematic portrayal of this, where we are in real life and how people have tended to study these things in the past. That is, mood disorders, cognitive impairment, and functional difficulties independent of one another. So we're really interested in the overlap. And it's definitely worth noting that these different manifestations actually share some specific brain circuits that are known to be affected in HIV, specifically frontostriatal circuits. And these clinical phenomena also share in common neuroinflammation and dysregulation of the dopamine system. So the idea here is to give these very comprehensive clinical evaluations and then do some pre-processing of the data. I'll talk about the different machine learning and clustering approaches we used here in a moment. So that was done with advanced computational methods. And our goal, again, is to try and get at this question of whether there are some core subgroups of individuals who share certain clinical and biological factors. This might, in the future, lead to better targeted therapeutic interventions, better diagnostic assessments, and so forth. So again, our goal was to identify longitudinal, so these are trajectories over the time, multidimensional biopsychosocial phenotypes, and characterize how they're associated with both demographics, HIV disease characteristics, and comorbid disease characteristics. So can we predict how a patient is going to do longer term by just looking at where they are medically at a baseline visit? And you can see I've listed what I mean by multidimensional here. Again, cognitive, depressed mood, and daily functioning. So the cohort is our charter study cohort, a little over 500 people with minimal exclusions to try and optimize the generalizability of any findings. I do have to point out that the data I'm going to be showing are from the 2003 to 2007 approximately period of time, during which our ART initiation guidelines were different from nowadays. So at that time, we were not offering ART to everybody with HIV, only to those who had experienced low CD4 counts or very high viral loads. So these are the instruments you see here that were used to assess cognition, so comprehensive NP testing, self-reported cognitive symptoms, and dependence in instrumental activities of daily living, and then self-reported mood using the Beck Depression Inventory. And our whiz statistician, Bin Tang, developed this two-stage machine learning approach to identify subgroups that shared important clinical characteristics across these four domains here. So the machine learning was done with self-organizing maps to kind of reduce the dimensionality of the data somewhat so that it could be better handled by the k-means clustering algorithms. So you may have seen a slide like this before. The components of the Charter Neuropsychological Battery, it assesses 7 domains of cognitive and motor functioning that have been shown previously to have high yield in the setting of HIV. The BDI has a number of subscales. I'm not listing all of the items here, but you can see there's an affective subscale with things like sadness and anhedonia. subscale with things like loss of pleasure, concentration difficulties, so a cognitive subscale. I mentioned that mood often affects perceived cognition and concentration. And then somatic things like loss of energy, tiredness, fatigue, and so forth. A little bit more on the patient's assessment of own functioning and IADL instruments. So what the PALFI does is ask whether the ask the study participant to compare their current level of performance in daily life with their perceived prior best or usual level of functioning. You can see it has a number of domains here. Some of them are more higher cognitive, and some are simply motor and sensory. And when a person reports at least two scores elevate or more than two or more elevated, they're considered clinically significant difficulties with daily activities. And then this is the IADL scale. So to what extent are people dependent on in a number of different domains of daily functioning, and then a summary score reflecting yes, no, dependent, independent. So this is just a schematic depiction of how the data flow through from this very complex, multi-dimensional through the self-organizing maps to some more manageable features, and then the k-means to group them into these clinical subgroups. I also should mention how we measured comorbidities. So some of you will be familiar with this Charlson Comorbidity Index. It's been around for a long time. There's a summary score, and then there are all these different components, including, by the way, AIDS, which for our analyses, the Charlson, the AIDS is excluded, and so you can see a number of the comorbidities that we all know are very common in our patients in clinic. And so what did we find? Well, here's where the good news comes in. The very largest phenotype, the very largest subgroup was this healthy subgroup. So a score in the downward direction is good. So you can see for the phenotype 1, they're all their domains are down at the bottom. The majority of the people, so again, this is the largest group, and I think that sends a really positive message. However, there are other people who continue to be affected, in some cases very significantly. So this is the green here is the second largest group. They've got very mild cognitive problems, but they also have depressed mood. And interestingly, over time, it is getting better. As you can see, this line going down. Similarly, their cognitive symptoms are getting better, and their self-reported activities of daily living are getting better. So this group, although they're not starting off at the greatest level, they're actually overall improving, with the exception of their cognitive problems, which tended to stay about the same. Then we have this group here, which really is very close to the healthy group on the cognitive side, but is severely depressed and continuously so throughout the duration of follow-up, which in this case was 18 months, by the way. And they have a high burden of cognitive symptoms despite doing relatively well on testing. and they self-report a great deal of difficulty in their instrumental activities of daily living. So basically, we got four groups here. We did a lot of comparisons between the healthy group and the other more adversely affected groups. In particular, this group 4 with worsening cognitive problems, but relatively stable in the other areas, and the highly depressed, self-reported, very impaired group. So how did they differ? Well, one way to look at this is simply to look at their baseline characteristics and see which groups sort of stand out. And you can see here that on average, those two, the healthy and the improving phenotype tended to be younger than the other groups. And they tended, at least the healthy group tended to have a higher education level. This is considered a proxy for brain resilience or reserve. They were more likely to be employed, and they had a better educational quality. Interestingly, they had shorter durations on ARVs, and they, despite having had very low CD4 counts, as you can see here, and they tended to have shorter duration of HIV, whereas people who were cognitively impaired and getting worse tended to have longer durations of HIV, more likely to be Hispanic, and a longer period on antiretroviral drugs. But as you can see, there's been substantial immune reconstitution in all four groups. And in fact, they didn't differ with respect to plasma viral load and their CD4 nadir or current. And this is kind of interesting because this was even in the era when we were not treating everybody with antiretrovirals. So the epidemic has been changing over time. Let's see, the things are a little out of line here. I'll just point out a couple things. Chronic pulmonary disease at baseline was least likely in the healthy phenotype and most likely in this very cognitively impaired and cognitively worsening phenotype. Lots of neurocognitive comorbidities, as you might expect in this phenotype 4. So these would be things like learning disabilities and traumatic brain injury and so forth. I mentioned that these things that our exclusion criteria were pretty liberal. So these people, some of these people do have a high burden of sort of premorbid neurocognitive comorbidities. There's a lot of neuropathy in the cohort, particularly in the more adversely affected phenotypes, least so in the healthy phenotype, but still almost a third. And then differences in the number of ARVs taken, as you can see here. They did not differ specifically at baseline in these areas. Now, but we're only looking in a univariable way here. So which of these is more important than others? Which of these baseline characteristics? So now we're doing multivariable modeling, looking at statistically independent baseline medical predictors of these longitudinal trajectories. And you can see comparing these two adversely affected phenotypes, the very depressed and functionally impaired and the very cognitively impaired, chronic pulmonary disease is a very, very strong predictor of those adverse trajectories. There's signal for lifetime substance use disorders, which interestingly were least in this very cognitively impaired subgroup. but quite high in the healthy phenotype. Or I'm sorry, in the phenotype 2. And then you can see neuropathic pain is also very common in the adversely affected individuals. And this is all adjusting for things like viral suppression and duration of infection. I expected to see more of an effect of polypharmacy, but that was not the case. And if I have time, I'm going to come back to this creatinine because this was somewhat of a paradoxical relationship, and some of you might be able to speculate about why creatinine levels were lower in these adversely affected phenotypes. Okay. Uh, my own take on this is that these are clinically very plausible subgroups of individuals, but in this case they were revealed not by a clinician looking at the overall profile, but actually using this machine learning approach. I mentioned the healthy phenotype was the largest. Uh, Disability in this cohort was primarily driven by depressed mood rather than cognition. And I just remind you that that phenotype 4 with a lot of cognitive impairment and worsening over time actually didn't report a lot of disability in their daily lives. Now, it's entirely possible that's because either they have poor insight or they've simply always been this way. Even before HIV, they were relatively lower function. Uh, there were substantial differences in demographics and treatment characteristics, as I mentioned, and there's a very strong relationship between chronic pulmonary disease, neuropathic pain, and the overall comorbidity index on predicting the subsequent trajectories. We had fewer females than, and that limited power, but the proportion approximates the US population of people with HIV. The ADLs were not directly observed, but rather self-report. We did not look here at the syndrome of major depressive disorder. Very, very few people actually have a major depressive disorder at the time they come in for a research study visit. Not terribly surprising. People who are very depressed probably are not going to come in for this day-long evaluation. So we've got severity of mood symptoms, not the syndromic definition of depression. Follow-up's only 18 months. The neurocognitive, you're aware that Alzheimer-related pathology is becoming increasingly frequent as people with HIV age. And some of the domains that we typically call Alzheimer-related were not fully assessed, but we did fairly well with them. And then we don't have the level of social data that we would really like economic disparities, stigma, built environment, social support, and so forth. So what does it all mean? Well, I think, we need to figure out why some depressed people with HIV are very impaired in their IADLs. Well, a smattering in the other groups were not very impaired. Are there some kind of resilience factors? Maybe it's social support, for example. I mentioned these interactions between cognitive difficulties and depression. Those are highly clinically relevant. I see this in clinic all the time. Specific phenotypes and associated risk factors actually might help us better personalize our intervention strategies. So for example, if you've got a depressed person without cognitive impairment, they're probably going to do reasonably well with psychotherapy, daily antidepressant medication. Where if you got a person who's challenged with respect to adherence because of both depression and cognitive impairment, maybe long-acting therapies are needed, like antidepressants and neuroprotective. And these are both in the future. We don't have the greatest long-acting medications in these categories, but they're definitely coming. So yeah, we need to validate this in other samples, look at how these trajectories change when you look at longer follow-up periods, and look at whether people transition from one cluster to another. We're in the process of looking at specific biomarker correlations. Maybe the biomarkers will give us some insight into what is driving the comorbidities, which in turn seem to a great extent to drive the adverse phenotypes. And if we better understand these things, we might be able to target treatment better towards inflammation or comorbid vascular disease. And then we definitely need to strengthen in the future our studies of socioeconomic advantage and pull in also see whether HIV persistence or reservoir size contributes to these relationships. So all those things are underway. So I'm going to stop there for a minute and just see if there are any questions.
Perfect. So one comment and then one hand up. So Miley wanted a clarification in regards to the baseline substance use. Did that include alcohol?
Yes, yeah. Any substance use disorder, including alcohol.
Okay. And then Jules Levin has his hand raised. Jules?
Hi, Ron. Hi, it's Jules.
Hey there.
So I have three questions. Number one, um, uh, um, so in the clinic, with HIV doctors and clinicians, my experiences and speaking to a lot of people and my own personal experiences is that many clinicians, if not most, are not really evaluating patients, people with HIV, for depression
Mm-hmm.
or cognitive impairment, like a MoCA or something else. And oftentimes I find patients' complaints to the doctors are often dismissed by doctors. So that's
Mm-hmm.
number one. And number two, um, research shows, which I know you're familiar with, I'm sure, that adverse childhood and adolescent events like child abuse and violence and so forth can later in life increase risk for depression and cardiovascular disease. So that's the second thing that I'd like you to comment. And then the last comment that I was hoping to get here is on oh yeah. So, as you said, it's an 18-month study, and I think you mentioned in your comments that you need long-term follow-up. So my main concern is, and it's a bit controversial, and the question is, older people with HIV, you already alluded to it by saying that Alzheimer's pathology is increasing as people are aging further into their late 60s and 70s. But we're not following people to look for trends in increasing cognitive decline in the elderly population. Do we really see worsening of cognitive function in a significant group of people as they age? So those are my 3 points to help you to comment on. Thanks, Ron.
Yeah, they're all great points. Um, With regard to the first one, we've been arguing for years that we got to do more in terms of screening. Now, none of us blames primary care providers. They're already overtaxed in clinic, but we got to you know, the Owen Clinic is a leader in trying to establish multidisciplinary programs, especially for older people with HIV, and we just need more of that. The childhood adversity, sexual abuse is a massive question. Incidentally, those things tend to travel with depression, so that's an important point to make. And then, what was the last one, Jules? It'll come to both of us in a minute.
The aging population, we're not really
Oh, yeah,
following people as they
yeah,
really age
yeah,
in their late 60s and 70s to see
yeah.
how much of an increase there is in cognitive decline.
Yes, absolutely. Um, uh, it's a very complicated issue. In the Charter study, we actually saw that older people tended to do a little bit better. However, that may result from people who were doing less well dropping out, so sort of a survival bias it's referred to. And you're right, we haven't done enough serial screening to look at trends over time. So hopefully this kind of study will push these issues to the floor and we can get more traction in the clinic. Okay, let's see. I saw one other
Yeah,
question.
so Jeff
Yeah,
Taylor just said this is why we need to enrich these cohort
yeah,
for old folks, not the
yeah,
majorities who are in their 60s.
yeah.
And Nettie said, I agree. We often quote unquote dismiss neurocognitive complaints from patients. There are frustratingly few resources for diagnosis and especially for treatment of these symptoms. I'd guess this probably makes us subconsciously not want to take on these concerns.
Yeah,
And Kathy
I
Promer
think that's
also said also
and
takes several months
and
to link to neurology. No
I'm
poke
just
at
one
you,
lone
Ron.
guy. No, that's not true. I have some supporting clinic. Um, but yeah, always trying to do better.
Yeah.
Um,
All right.
okay,
So
well, let me move on to this issue of compartmentalization. Now, at the very beginning, I talked about what many of you are familiar with the issue of viral compartmentalization. You know, is there different, can the virus in CSF be elevated when it's undetectable in plasma? Do the genotypes that you find in CSF differ from those in the plasma and so forth? But I'm actually going to talk about other biomarkers. So let's get into it. So we wanted to see how they were regulated across blood and CSF, understand how blood-brain barrier integrity influences the relationships between the two, look at whether viral suppression influences this cross-compartment regulation, and at whether specific ART classes or drugs might influence the regulation across the two compartments. And to put this in perspective, we need to remember that the CNS generally favors a tightly controlled environment. And there's this, you know, that's meant to protect neurons, delicate neurons from all the chaos that's going on in the periphery. But you need also to be able to balance that with having the two compartments talk to one another. And you're going to see this tension emerge in the patterns of correlations I'm going to talk about. Then here is the blood-brain barrier. So behind a wall and a moat, CSF is in here. And when the blood-brain barrier gets disrupted, these warriors can breach the gate in the wall and affect neurons. Some of you may be familiar with sickness behavior. I think many of us have felt when we have a bad flu or something, that our brains don't work well, we're very fatigued, and we tend to withdraw from social activities. And if this turns out to be a very important thing, then we should think about ways to stabilize the blood-brain barrier while allowing essential crosstalk between the two compartments. All right. Uh, we believe that cytokines and chemokines and other biomarkers are relevant not just diagnostically, but also therapeutically in that they might give us clues about underlying pathophysiology. I mentioned the need to to balance the immune privilege and protection between the two compartments. That might tell us when we should be measuring them in CSF versus plasma, or would both of them be important? To look at the blood-brain barrier integrity issue, we stratified by CSF serum ratios of protein. I'll talk about that in a minute. But this is, if it's elevated, it favors breakdown in the blood CSF and blood-brain barriers. Bin did some sophisticated clustering to highlight relationships between the biomarkers. In other words, within a compartment and between compartments, do different biomarkers tend to travel, go up or down together? And I mentioned the potential diagnostic and therapeutic implications. So just a quick refresher on the where does CSF come from? You remember it's made by the choroid plexus, secreted into the lateral ventricles, and then it distributes around the brain and gets reabsorbed in the arachnoid villi. Then we have the CNS also makes a contribution to CSF via the interstitial fluid, the space between the cells. So here's a little bit more detail on that. So we have subarachnoid arteries. They send off branches that penetrate into the brain parenchyma. They carry with them a perivascular space that we've learned recently is extremely important in that it kind of serves as the lymphatics of the brain. And within that space, the perivascular space, interstitial fluid from the brain contributes significantly to what's found in that perivascular space in terms of biomarkers and cell populations and so forth. And then within the brain parenchyma, astrocytes and neurons and microglia also contribute to what you see in the perivascular space in the spinal fluid. Okay, so I kind of already went over this, but just a quick summary slide. Blood CSF barrier and blood-brain barrier are somewhat different, but share some characteristics. There are tight junctions, but they're less restrictive at the blood CSF barrier, more so at the blood-brain barrier. And then there are various transport mechanisms to control what's able to come in, what's able to go out. And then there are different cells that affect the blood-brain barrier and the blood CSF barrier. So systemically, immune regulation is T cells, B cells, and macrophages. They don't have major physical barriers. They have broad antigen diversity. They make patients susceptible to cytokine storms. And in the periphery, it's endocrine signals that regulate immunity. By the same token, within the CNS, the immune cells are microglia and astrocytes, and to some extent, periventricular macrophages as well. The CNS peptide recognition is very CNS specific, requiring MHC class 2. You have localized inflammation that's tightly controlled within the CNS, and then to transduce signals from the periphery into the CNS to affect inflammation, it's the vagus nerve. So instead of an endocrine mechanism, it's actually a peripheral nerve. So we formulated this overall model. We expected some of the biomarkers to show strong CSF, intra-CSF or within compartment correlations, but relatively weak associations with plasma. We expected some biomarkers to be co-regulated across compartments, and then some biomarkers that would, whose correlations would change based on the blood-brain barrier permeability I was talking about. So this analysis was from a subgroup of the people in the prior cohort who had had lumbar punctures. This is not a longitudinal, but a cross-sectional analysis. I mentioned relatively few exclusions. They all gave paired blood and spinal fluid samples, and we were careful to process the samples so as to optimize biomarker stability, because many of these samples are quite old now. Okay, so how do we measure blood-brain barrier integrity? Well, we didn't actually have the gold standard, which is albumin. So we had a proxy for that, which is the protein ratio. And previously, it's been shown that this is a very good surrogate for albumin levels. We used a multiplex O-link panel to measure markers of inflammation, immune activation, neurodegeneration, and then we assessed these intra and intercompartmental correlations. I mentioned that. Okay, so this is the overall panel, lots and lots of biomarkers. I'm not going to go through these in detail here, although I'll mention some specific ones as we go along. You can see immune activation, inflammation, neuroinflammation, and a variety of other pathways. So Bin Tang, who again did these analyses, did some data pre-processing, did simple correlations, and then used some more sophisticated techniques to try and better understand the data. Everything's adjusted for multiple comparisons. She looked at established string and KEGG databases that give you a sense of what pathways do some of these biomarkers share, common biologic pathways, and then we had a variety of visualization approaches. So won't spend a lot of time on this. I'll just mention again, because of the time period of this cohort, we had both unsuppressed and suppressed participants, approximately equal numbers. The suppressed people tended to be older, have longer duration of HIV and treatment. And while both groups were immune reconstituted substantially, nadir CD4 was lower in the suppressed group, exactly what you expect, given that was the major indication for prescribing antiretrovirals. Okay.
Time check,
So,
Ron, just
yeah.
8:44. So just letting you know.
Okay. Yeah, I think we're good. I think we're good. Okay, and we'll have a little bit of time for more questions at the end. So let's see. This is the big picture, the 20,000 foot level. And what's immediately apparent from this is that biomarkers within the plasma tend to be correlated with each other. Biomarkers within the CSF tend to be correlated with each other. And across compartments, much weaker correlations. So again, those weaker cross-compartment correlations, again, are potentially consistent with some systemic co-regulation of specific biomarkers, and we'll see that more in a minute. So just a sampling of some of the correlations that stood out. So here's a biomarker, CXCL9, involved in cellular trafficking that is strongly correlated between the plasma and the CSF. It makes sense that cellular trafficking might be co-regulated, at least in part. And down here is another biomarker where there's virtually no cross-compartment correlation. The effect of plasma viral suppression on the between compartment correlations was relatively modest but present. And did not overlap with the blood-brain barrier. I was kind of expecting that people who weren't suppressed would also have more blood-brain barrier breakdown. That effect was minimal. Viral suppression still, however, had some effect on the cross-compartment correlations. And then, as you might expect, if you had a detectable CSF HIV RNA, lots and lots of biomarkers correlated with that, whereas the plasma biomarkers did not correlate with CSF viral suppression. So again, very strong evidence of compartmentalization of immune and neurodegeneration responses across compartments. We did see some, again, modest effects of the blood-brain barrier. So what are we looking at here? Well, this is just a selection of the biomarkers, CSF on the y-axis, plasma on the x-axis, and then groups subgrouped according to blood-brain barrier function. So these are the leakiest blood-brain barriers. You can see, again, modest effects, but if you scan across these 4 biomarkers and then look down here, those with the leakier barriers tended to have higher cross-compartment correlations. This is another way of demonstrating the same thing. So some correlations relatively insensitive to permeability, others strengthening very significantly in those who had increasing blood-brain barrier permeability. So in summary, across these simple compartmental intra and intercompartmental correlations, it looked like the plasma within compartment correlations were present but generally weak compared to CSF within compartment correlations, suggesting that although the plasma is regulated separately, it's a much more heterogeneous in terms of what biomarkers are traveling with each other. Whereas in the CSF, much overall stronger within compartment correlations, and the between compartments, as I mentioned, were relatively weak, reinforcing how the blood-brain barrier restricts trafficking or co-regulation. There was, just in brief, no significant moderation effect of specific ART regimens on the biomarkers. Okay, so this is a more sophisticated canonical correlation analysis where the goal is to look to see whether there are coordinated cross-compartment interactions involving multiple biological pathways. So you can see here, CSF CXCL10 is highly correlated with plasma CXCL9. Up here, you can see a cluster of CSF biomarkers that is also related to the plasma CXCL9. And then down here, you see some more biomarkers that tend to be correlated within compartment, whereas here, we're getting some crosstalk with the CSF biomarkers. And interestingly, this CSF and plasma FGF 21, these just traveled together between CSF and plasma, but were very independent of the rest of the biomarkers. So we looked in carefully. By the way, I'm not showing you all the sophisticated pathway analyses, but I'll summarize some specific individual biomarkers that I think really make sense. These are the pairs that I'm going to tell you about here. First is MMP10, IL-10, and then hepatocyte growth factor. All of these are involved in matrix, extracellular matrix remodeling, tissue repair, blood-brain barrier permeability, and so probably reflecting glial activation within the CNS compartment, astrocytes and macrophage and microglia. I mentioned that these are involved in both inflammatory and anti-inflammatory signaling, and to some extent neuroprotection and angiogenesis. So another set of biomarkers, and this is an example here, CXCL10 and TNF receptor SF9. All of these together are involved in recruiting T cells and monocytes across the blood-brain barrier during neuroinflammation, which makes sense to me in terms of those being blood-brain barrier dependent correlations. And then TNF superfamily also involved in activating cells, inflammatory responses, and becoming more coupled across compartments in the setting of blood-brain barrier dysfunction. And then, as you might imagine, both the chemokine signaling and TNF signaling relate to cerebrovascular endothelial activation, which tends to travel with blood-brain barrier compromise and leukocyte translocation from the periphery to the CNS. A last pair, I'll just mention VEGF-A and CD8A. These are involved in, and these were classified as systemically regulated biomarkers, so similar across compartments. And these are involved in vascular signaling and T cell activation. So I guess the overall point here is that this compartmentalization isn't just noise, and it's a biological signature that we may be able to exploit to help us better interpret the things that we can measure in spinal fluid. And I kind of made these points. I also think now this kind of analysis really hasn't been done to this magnitude in other conditions, but certainly in neuroimmune conditions like multiple sclerosis and in Alzheimer's and Parkinson's diseases that involve a inflammatory component. These are definitely worth looking at, and you might expect, given the different pathogenesis, that these would be somewhat different across different degenerative disorders. I'll mention two other quick things that I think will further enhance our ability to interpret biomarkers. Mattia Tronfio and Scott Latender are working on writing up these analyses. A stunning high degree of correlation between the same biomarker measured in spinal fluid at a first visit and at a second visit 12 years later, suggesting that, there's something that's conferring a biomarker set point in CSF that isn't present in plasma. And that set point may be related to the need to tightly regulate what's going on in the nervous system. You can imagine that if I didn't know that these were so highly correlated, this correlation would overwhelm any other kinds of clinical correlations. So knowing this really gives us a new tool to better interpret our biomarker concentrations. And last but not least, Daniel Lima is starting to evaluate whether those high correlations that in CSF that we saw here are related to specific genetic variants. And there do seem to be some important determinants. This is a targeted rather than a genome-wide association study. And so I also think that this will help us better interpret what we're seeing in spinal fluid. And I'm going to stop there, and we've got a few minutes for questions.
Great. Thanks, Ron. So Jeff Taylor asked, I've been hearing about the brain CSF microbiome. Is this something you're looking at?
It's being looked at. I'm not prepared to say anything about it, but certainly Katie Riggs is very focused on the CSF virome. There are new kind of multiplex platforms that are helping us better assess the virome. And yes, there is a microbiome in the plasma and the CSF, and people have started looking at those.
Okay, I'm gonna actually let me ask Sarah's question, then we'll get to Jules. Sarah said, this is very interesting from your research and clinical experience. What pearls of wisdom do you have for HIV PCP seeing these phenotypes daily? Any up and coming treatments, pharmacologic or not?
Yeah, a lot of work remains to be done. I mentioned that I find these to be compellingly believable subgroups of individuals that will require different care modalities. I speculated about the potential impact in very depressed, cognitively impaired people of using long-acting therapies to address their difficulties with adherence. Alan Winston and others have argued that all their patients are healthy. They don't have any problems. We do see a substantial number of people who are, in fact, doing very, very well. And then we've got a lot of people who seem to have premorbid comorbidities that unfortunately are hard to address beyond just trying to treat any medical conditions that might be contributing to their depressed mood and cognitive problems.
Okay. Jules?
Hi, nice talk. Thank you, Ron. Two questions. One, I think Scott presented at Croy a few years ago. That's probably more than a few years now. And you might have been part of that group. I think it was a poster. Looking at all the ARTs and the association with cognitive function. And he found in his table that every ART was associated with some degree of cognitive impairment. And recent research has found, even in animals, in an animal model out of the University of Pennsylvania, it's been published, that integrase inhibitors were associated with decline in cognitive function, associated with brain damage. So, I know you found that there's no difference between ART classes, but maybe they're all, have
Yeah.
some effect on causing cognitive decline
Let
over
me
many
just
years.
comment there, if I may.
Yeah.
So it's not that the ART regimens didn't affect cognition and mood. It's that they didn't influence the compartmentalization issues of the biomarkers. So I hope I didn't confuse about that. As exactly as you say, there's definitely signal there for effects of different medications and medication classes on cognitive function and mood. And we are doing or collaborating with a woman named Anne Bang to study in vitro what happens when you put these antiretrovirals in concentrations that reflect clinical levels. What happens when you put them on a culture of neurons? And in fact, some of them cause neurite retraction, some of them cause mitochondrial stress. So yeah, there's a lot to unpack there.
And the other question is, so you talked a lot about inflammation and markers. So my question is, did you find an association with the markers, the prevalence of the markers and the impact with current CD4 and CD4 nadir? And with that question, I would assume that lower native CD4 and lower current CD4 might be associated with higher, prevalence and worse outcomes. But the other question with that is, what in the more current day, where people start ART with higher CD4s, they still seem to have inflammation. And so, to what degree can we expect the same kind of effect in people who even start ARTs with over 500 CD4s in the future?
Yeah, that's a lot of questions. Maybe I'll just say that what was the very first part? Because
Was the prevalence of inflammation markers and decline
oh
associated
yeah.
with low
So
native?
as a matter of fact, it was very weakly or not correlated with disease markers, with the exception of the CSF viral load being strongly correlated when it was detectable with higher levels of many, especially of the inflammatory immune activation markers.
Well, I'm just going to say I'm not sure I buy that. I think CD4 nadir is associated with higher inflammation.
Um, Generally, if you have a low CD4, you'll have had more inflammation in your CSF. That doesn't mean that it's still there when you immune reconstitute. And again, it's not that it normalizes completely, it's that it does improve with viral suppression. So I hope that's clear.
All right.
I'm
Okay.
not disagreeing with you. I think we're kind of agreeing, at least in part.
And what about in the current day, people who start ART with over 500 CD4? They still have inflammation. So what's their long-term risk?
Yeah, we don't have enough of those. You saw the CD4 nadirs in this cohort. Uh, so that's a question that needs to be looked at. And I'll point out that one of the best studies to address that is the Thai longitudinal study, where they enroll people during acute infection and get them on ART, in most cases right away. In many cases, before they even seroconvert, they just have an acute HIV seroconversion illness.
All right. Well, it's a little bit over time. Really appreciate everyone's participation today, and thanks, Ron, for a wonderful talk. Everyone have a great weekend, and hopefully we'll see you next week. Thanks again, Ron.
Great.